Final presentation, Nicolas Roche from Paris, ACOS, combination therapy in ACOS. Nicolas, the floor is yours.
Okay, thank you for this very kind invitation to talk about ACOS. When I read the topic you gave me, the first question I asked myself was, why me? Why do you want me to talk about ACOS? Why didn't you choose somebody else? Because the second question...
Is Rob here?
Yeah. Because that's you. Because the second question I was asking myself is, what is ACOS? And it's very, well, just before you had very nice people presenting very nice talks on asthma, which we believe we know a little bit what it is, COPD, same, and now ACOS, and I think that most people in this room, and at least in my bedroom when I'm alone in it, most people don't really know what ACOS is. So with ACOS, as with asthma or COPD, I would have some disclosures. And I was thinking of what we could imagine in terms of combinations therapy for ACOS. And it could be LABA plus LAMA, LABA plus ICS, LAMA plus ICS, but I was just thinking about the fixed combinations here. And soon we're going to have LABA plus LAMA plus ICS. These are just the inhaled fixed dose combination that are or will soon be available. And well, instinctively, I was thinking that when speaking about fixed dose combination, the most useful for ACOS could be or should be LABA plus ICS, just coming from some logic. But then, going back one step, I think it's quite important. What is ACOS? So what are we talking about now? Is it something new? No. It's not that new. It's probably at least 30 years old, as you can see from this graph here. Where you have ACOS, it's there. So it's a reinvention of something that we already knew exists, which is just when you have both asthma and COPD features. And when you look at the definitions, I think the definitions of asthma, COPD, and ACOS are very interesting, because I believe that when you need such a long definition for a disease, it means that you are in trouble because you don't really know what the disease is. And that's true for the three of these, asthma, COPD, and ACOS. There is a problem there. I don't really know where it is, but I know that adding a third disease or syndrome with another long definition doesn't solve the problem. Maybe. I'm trying to be a bit provocative, as you might see. So what is ACOS? And I went back to all the literature that we got these recent months or years on ACOS, just to try to understand what the concept is and where we are going. So when you look at this literature and you try to answer the question, what is ACOS? First thing, is ACOS a disease? No, by definition it's not a disease because it's ACOS, so it's a syndrome. But when you look a bit deeper to the literature, it's not a syndrome. At least Peter Barnes said just a few weeks ago that it is not a syndrome. It should not be called ACOS, but ACO. ACO, what is it? It's asthma and COPD overlap, meaning when you have a bit of both. But it is not a syndrome because within ACOS, you have different phenotypes, different endotypes. So it's not logical, and it doesn't fit the definition of a syndrome to call ACO a syndrome. Is it just asthma plus COPD? When you look at the definition I showed you, I didn't give you enough time to read it, I hope. But when you look at this definition, it's not only asthma plus COPD. Is it a specific phenotype of asthma or a specific phenotype of COPD? Not really, at least that's not what the definition tells us. Is it going back to non-specific lung disease, the Dutch hypothesis 40, 50 years ago now? Maybe, in a way. I'm going to talk a bit about this. Is it eosinophilic COPD? Is it reversible COPD? Is it neutrophilic asthma in smokers with fixed airflow obstruction? Well, it could be all of these. And do all these possibilities build a syndrome? Probably not. So this is where we are and maybe where we are going to. Where we are now is we have two diseases and one syndrome in between, which is what we are able to name. But when we look at all where this comes from, the interaction between susceptibility factors and the environment and molecular mechanisms, endotypes, what we get is not two diseases and a syndrome. It's this huge addition of intricated phenotypes or endotypes. So probably we can say that this is where we are now, and maybe this is where we come from and where we're going back to. The problem is that we don't know for now how to define all of these. So we have to do what we can, what we know how to do, which is just stay with asthma, COPD, and I still don't know what ACOS is when looking at this. But even if we don't know what it is, some people are able to calculate its prevalence, which is difficult. And the problem is that since you have many definitions of ACOS in the literature, not just the one I showed you, the prevalence is very variable. And that's what you can see here. You have various studies with COPD only, asthma only, and ACOS in all these studies. And the respective proportions of all these things, I will say, are variable. So that's a problem. When you have such variable prevalence, it means that somewhere you don't really know what you're talking about. Excuse me for being, again, a bit provocative. And here you have the illustration. I like this one just because it has some colors. This one is very nice because each color tells you the definition that was used to define asthma and COPD in all these studies of ACOS, which is having features of both asthma. So you can have features of asthma as a diagnosis and COPD defined by spirometry, or asthma defined by spirometry and COPD defined by spirometry, etc. So all these are ACOS. It's just the way they are defined clinically, administratively, just with the ICD codes, or with spirometry. So when the definition differs, the prevalence differs a lot. There is a problem. But even if we don't know how to define ACOS, there has been a systematic review on ACOS. Again, nice. Smoking. ACOS, people smoke less than COPD, which may be because they don't have COPD, but only a part of COPD. So they have smoked a part of what the people with COPD do. Lung function, very variable between studies. So impossible to have any conclusion because it depends how you define things. Exacerbations. People with ACOS have more exacerbations than people with COPD in most of the studies on this topic, but not all. Health status. People with ACOS have poorer health status than COPD, who have poorer health status than asthma. These two, what does it mean? If you think that ACOS is having a bit of asthma plus a bit of COPD, it means having, in a way, two diseases. And this means that when you have two diseases, you're more sick than when you have only one. You have more exacerbations, you have poorer health status. That's quite logical. Some of the features that you could use to define ACOS are eosinophilic inflammation or reversibility. The problem I will touch a little bit on eosinophilic inflammation, but it has already been alluded to. Reversibility, can you define ACOS as people with COPD and reversibility? The answer is clearly no. Why? Because reversibility is not stable over time in people who have COPD or who have a diagnosis of COPD. So you can't use a feature that is not reproducible within a given patient to define a disease or even a syndrome. That's not possible. So, that was a bit of an introduction. Now, we have asthma guidelines, we have COPD guidelines, and now we have ACOS guidelines. Shall we provide all asthma patients with the same treatment based on these guidelines? That's one question. These are the asthma guidelines. You've already seen that. The cornerstone of the treatment for asthma is ICS. And you can combine ICS with various types of other treatments. But the cornerstone, for now at least, is ICS. In COPD, you can also use ICS, but I would say that it's not the cornerstone of the treatment for most patients, at least that's what I believe. The cornerstone of the treatment here is bronchodilators, because these are the treatments that you can see in all the gold categories. You will have bronchodilators. So cornerstone of the treatment for asthma, ICS; for COPD, bronchodilators. And then, logically, for ACOS, what's the cornerstone of the treatment? It's both, because you have a bit of one, a bit of the other, features of both. So ICS, mandatory because there is some asthma, and you have to consider long-acting bronchodilators, antimuscarinic or beta-2 agonist, because you have some features of COPD, at least if the patient has the symptoms of COPD, which is exertional dyspnea. So we have asthma guidelines, we have COPD guidelines, we have ACOS guidelines, which combine both. The other difficulty that we have, which is, well, for now it's a difficulty, but it's a source of progress, is that we are trying to move towards more personalized medicine, which is that we are not treating asthma or COPD or ACOS. We are treating an individual who has specific features of airway diseases, and we are going to try treating these features in this given individual rather than treating a disease. You've already seen that. It is complex. This is just asthma. And you have several phenotypes, endotypes, and depending on the way it has been thought about, you will see these kind of graphs in quite different ways. So the message is that there are several phenotypes and endotypes within asthma. In COPD, you have also inflammation as in asthma. But as you know very well, this inflammation is less sensitive to inhaled corticosteroids, and the use of steroids in COPD has been debated. I won't go into the details, but it just means that depending on the biology of this given patient, of the endotype, you might use or not use these inhaled steroids. Which biological features can you use to determine whether your patient with COPD, and maybe also your patient with ACOS, it will be sensitive to inhaled steroids? These are the eosinophils. And there are several studies. I will not touch upon them again. Several studies suggesting that eosinophils are a marker of the risk of exacerbations and a marker of the potential efficacy of inhaled steroids in preventing exacerbations. The problem is that all these are post-hoc analysis, so for now we need still a prospective validation of all this before we conclude and before we use this in clinical practice. So several phenotypes of asthma and endotypes, several phenotypes and endotypes of COPD, I just showed you. And now for ACOS it's the same. We are having several phenotypes or endotypes of ACOS. What a mess, what a mess. But even if it may look like a mess, it's quite logical. Because at the end, when you look at all these, probably you're not able to read this, but you should go and read this paper, which is very good. We have genes, we have ontogeny, we have environment, and we have diseases. And the way all these interact is very complex. So we are probably just at the beginning of our understanding. And that's what explains why the definitions are a bit complex, because we are not there yet. We don't understand everything. And the question that's been asked everywhere now when speaking about ACOS and asthma and COPD is that, are all these the same, a continuum of the same disease? which means going back to the Dutch hypothesis 50 years ago. Maybe they were right. But do we need to treat a disease again? Do we need to treat a syndrome? No. I told you that we need to treat a patient. We need to treat this patient's characteristics. And this is a paper recently published, it's published now in the ERJ, which is interesting. It tells us that we have to identify the characteristics of the patient in front of us, and then from these characteristics we're going to decide the treatment. What is it? This is medicine. This is what we are doing. Should we forget about asthma and COPD and say that all patients have some kind of ACOS or whatever you call that? They have an airway disease with Th2 high, Th2 low, eosinophilic, neutrophilic, postgranulocytic, and depending on this endotype, we're going to choose the treatment. So you can do that without naming by a name of disease what you have in front of you. Why not? This is the Golden GINA guideline on ACOS. So you have asthma, COPD, or both. You treat asthma, COPD, or both with a combination. So the combination is perfectly logical. So to finish, what's the evidence on ACOS? What do we have to make our mind? And what's the most important? That's the question I ask you, and I think this is the most important question. What's the most important thing we have to do? Is it to diagnose ACOS, or is it to apply for now a proper differential diagnosis between asthma and COPD? And I believe the second option is valid now. Maybe in the future it will change, but for now we're not there yet. We are still trying to decipher all these endotypes, phenotypes. And for now, at least for the basic clinician, we have to stay with what we know a little bit, which is asthma and COPD. And the problem is that for now people are confused. This is data from a cohort in which you see that GOLD A and B patients receive a lot of inhaled corticosteroids. Why is that? Because people don't really know what they do. So before confusing even more all this by creating this ACOS, I think we have to go back and teach people how to differentiate the diagnosis between asthma and COPD, because it's not that difficult. In probably something like 80% of the patients that come to us with symptoms of airway diseases, if we apply all this, we are able to make a differential diagnosis. But the problem is that if you say to people, now there is ACOS, you have sometimes 50% of the population with airway diseases, which is labeled ACOS, just because if you do that, you don't have to think too much. So ACOS should not become the umbrella of all respiratory diseases now. And last, I'm going to try answering the question that was asked, which is, what's the evidence for combination therapy in ACOS? And that's the evidence. There is only one study specifically designed to assess one treatment, a combination of treatment in patients with ACOS. You see there is a huge number of patients there, and they were followed during a very, very long duration. What does it tell us? It tells us that one combination of beta-2 agonist and ICS does the same as, or maybe a bit better, but roughly the same as another one. So the answer is a combination of ICS and long-acting bronchodilator works in ACOS. Okay. Conclusions, there is almost no evidence. I would say there is no evidence. Asthma, cornerstone ICS. COPD, cornerstone bronchodilator. ACOS, cornerstone both. That's simple. The main conclusion is that we need much more research addressing the most important question, which is, does ACOS really exist as a single specific clinically relevant entity? And maybe it's not the case. Thank you.
Thank you, Nicolas. There is time for one question,
Good.
which is...
I prefer that than if it was time for me.
You want? Yeah, Leo, otherwise I would have one.
Nicolas, thank you. Would you give Luca mepolizumab to a patient with COPD and 10% eosinophil? No.
If you demonstrate that it works, I would.
Yeah.
Good. But is it your view? Okay, thank you. Lunch is ready. Lunch is ready next door. We reconvene at 2:30.